Okay, let's set the scene. You have diabetes, and you start feeling that classic numbness or pain in your feet. The diagnosis seems, well, obvious, right? It's got to be diabetic neuropathy. I mean, it's the usual suspect, and for a very good reason. But what if that open and shut case is actually a classic case of mistaken identity? Today, we're going to play detective and follow the clues to unmask a very sneaky imposter. And the scale of this problem it's just immense. Get this, up to half of all people with diabetes will eventually develop peripheral neuropathy. That's nerve damage. It's so incredibly common that, it almost becomes this automatic diagnosis, a rubber stamp. And that's dangerous, because it can overshadow other really important possibilities. And right there, that's where our medical mystery really begins. We're going to dive into a scenario where that automatic, easy diagnosis is actually masking a hidden condition, a true imposter, hiding in plain sight. So, who is this imposter? And more importantly, what's really at stake here? Well, believe it or not, in up to 10% of these cases, the real culprit is something called chronic inflammatory demyelinating polyneuropathy. Yeah, it's a mouthful. We'll just call it CIDP. Now, here's the absolute game changer. Unlike diabetic neuropathy, which we can only really manage, CIDP is treatable. It's your own immune system on the attack, and we have ways to stop it, and in many cases, even reverse the damage.
All right, so how do we unmask this imposter? How do we tell the two apart? Our investigation starts with the first and maybe the most telling clue of all, the clock. The speed, the timeline of how your symptoms develop, it's a massive giveaway.
Think about it like this. Typical diabetic neuropathy, or DPN, has what the source material calls a glacially slow progression. I mean, it just creeps up on you over years. So slowly, in fact, that you probably can't even pinpoint when it started. But CIDP? Oh no, it plays by a totally different set of rules. It comes on much faster, what we call a subacute onset. We're talking a noticeable, whoa, what's happening, kind of decline over just 2 to 6 months. And let me tell you, the difference here is it's traumatic. This isn't some subtle little variation, okay? It's a completely different footprint in time. So ask yourself, is this a vague issue that's kind of been bugging you for years, or is it a significant, rapid decline that you can pretty much put on a calendar? Because that rapid change, that is a huge, huge red flag. Okay, so our investigation continues with clue number 2, because it's not just about when the symptoms show up, it's also about where they appear on your body. The physical pattern, that tells a really crucial part of the story.
You see, DPN, it almost always follows this very predictable script. It starts in your longest nerves, way down in your feet, and then slowly creeps up your legs, kind of like pulling on stockings. Then, later, it hits your hands, like putting on gloves. And it's symmetric, the same on both sides. But CIDP, it's a total rule breaker. It's often asymmetric, hitting one side of your body way more than the other. It can be patchy, or, and this is a big one, it can start proximally. That just means closer to your torso, like in your hips and shoulders.
And this leads to a really powerful aha moment from the source material. This is a big one, so listen up. If you have significant weakness or numbness in your hands before your feet are really, really bad, that pattern is, and I'm quoting here, virtually incompatible with DPN alone. It's like a giant flashy neon sign pointing directly towards CIDP. All right, that brings us to clue number 3. And this one zeroes in on the type of symptoms you're having. Is this mainly a problem of what you can feel, sensation, or is it a problem of how you can move, your motor function? Because believe me, the answer to that question can change everything. So DPN, it's all about sensation. The main complaints are things like pain, burning, tingling, numbness. Weakness, yeah, it can happen, but it's usually an afterthought. It shows up late in the game and it's pretty mild. But CIDP is the total opposite. It's a motor-dominant disease. The number 1 defining feature is weakness. We're talking real trouble climbing stairs, getting out of a chair, or lifting things you used to lift just fine. And there's actually a super simple, really elegant test that clinicians use to spot this exact difference. It's called the chair rise test. It's exactly what it sounds like. You just sit in a regular chair, cross your arms over your chest, and then try to stand straight up without using your arms to push off. Now, the significance of this one simple action is it's profound. If you can't do it, it's not just about being off balance, it's a crystal clear piece of evidence. It strongly suggests weakness in your hips and thighs. Remember that proximal weakness we just talked about? Well, that is a key hallmark of CIDP, and it's not something you typically see with DPN.
Okay, so let's pull all these clues together. Just like a detective, a doctor has to take all this evidence, the timeline, the pattern, the type of symptoms, and piece it all together to build a really compelling case for what's actually going on.
So here's a quick summary of those critical red flags you need to watch for. A rapid progression, over weeks or months. Symptoms that are asymmetric, not the same on both sides. Weakness that starts up in your hips or shoulders. Weakness that is way more noticeable than any numbness or tingling. And here's another big one from our source, any facial weakness. If you've got any of these, it should trigger immediate suspicion.
So what's the logical path here? How do you go from just a suspicion to a real confirmation? Well, it all starts with those clinical clues we've been talking about. From there, you might move on to electrodiagnostic tests. Those are the ones that check how fast your nerves are firing. That can be supported by other tests, like a lumbar puncture, and sometimes the final confirmation is actually trying a CIDP therapy and seeing if you get better. The response to treatment can be a diagnostic clue itself.
And this right here is the heart of it all. Why does all this detective work matter so much? It's because getting the right diagnosis doesn't just change the name on your chart. It can completely, radically change your future.
I mean, just look at this side by side. With DPN, the goal is basically to manage your symptoms. For CIDP, the goal is to stop the immune attack that's causing the problem. With DPN, treatment is things like pain medication. With CIDP, it's powerful immunotherapies. For DPN, the best case outcome is slowing the decline. But with CIDP, there is real, genuine potential for improvement and even remission. These are two totally different worlds.
And that right there, that captures the ultimate cost of getting this wrong. Missing a CIDP diagnosis isn't just a simple mistake. It actively denies a person the chance to get treatment that can save their mobility, save their independence, basically save their function.
So this brings us to the final powerful takeaway from our source material. A critical question that really should be asked in every single exam room. Does this patient's presentation fit perfectly with what I expect from diabetes alone? Because if the answer to that question isn't a clear, confident yes, well, that's your signal. That's the sign that it might be time to investigate further, to go on the hunt for that imposter, because finding it could change absolutely everything.